division of the um, Chief Division of the Congenital and Pediatric Cardiac Surgery in one of the, if not the leading heart center all over the world, Cleveland Clinic, Ohio. Welcome, Dr. Hani, and we're really honored to have you here in our academic activity.
Well, thank you so much for the invitation. It's a pleasure to see all of you. I wish I could see actually all the faces joined in, but I'd love to be with you. It's a pleasure to be with you, and thanks for this initiative. I was in your shoes before, and I tell you, it may look, it's an amazing achievement, but all of you can do this. This is not special to me, and I'm not a special person or an incredibly smart guy. I'm sure among you there are a lot of people who are incredibly smart and achievers. I would love to share with you some of my experience that has led me to where I am now. I'm very thankful to God first, to my parents, to my family for all support, because this really is a product of multiple things that has happened. There are a lot of people who came through my way that got me to where I am now. I know that there's not a direct feedback. I hope there is some of the program directors signed on. Having said that, if not, I would love that I could one day communicate with the program directors in Saudi Arabia so we could share some of the ideas. So I was asked to talk about innovations. So I prepared some presentation, and I'd like all of you to be engaged in this. Please write some notes. It's the different types of areas that I'm going to talk about. And it's not about how I got there. It's about how you want to become where you want to be. I am sure that there will be different times and areas that you are going to be in exactly the same position I am, and always strive to be the best. So let me just share my presentation. Can you see my screen now and my slides?
Yes, it's very clear.
Perfect. All right. Is there a place for innovation in heart surgery? I have no disclosure. So I was asked by Luay to share with you some of the objectives of this, and I asked him actually to share the objectives. So how to promote innovation among cardiac surgery residents. We'll talk about that. Personal experience in innovative procedures in congenital cardiac surgery. We will talk about that. How to improve cardiac surgery training in Saudi Arabia. I will talk about that. Role of cardiac surgeons in innovative catheter-based interventions. That I don't have a huge experience with, but we can relate to some of the talks that I will talk about. And then I'll end up with some highlights on the Hani Najm Global Scholar Award. So if you look at the dictionary and you look at Oxford Dictionary and you look at the definition of the use of creativity, the use of imagination or original idea to create something, or what's called inventiveness. So it is not a chance that people come with creative ideas and with innovations. If we were to talk about how could you, as a surgical resident and a surgical career surgeon, what can you, or what types of innovations you can do? Now, I have concentrated on the technical innovations, but that is not the only area that you could innovate with. So I put in some of the ideas that you want to think about as you go along. And I have done more than the technical. I have also devices. So you can think about devices or instruments. Now, I will tell you a little bit about that. It is not easy, and you need a good infrastructure and work with engineer. And I will talk to you a little bit about that. You can talk about new surgical procedures or techniques, and I will share with you some of the new surgical procedures that I've innovated through my career. You can talk about new application of existing techniques or devices. That is some other techniques that have been published and reported, but use it in a different way that would be of a greater magnitude. And then you have the integration or linking of existing techniques in a new concept. So, and I will share with you what I mean with all these little different areas of innovation that you can do in cardiac surgery. So I started off with a problem. So you always see, what do we have a problem? We do have a problem of a valve that doesn't grow. Most children, if they ever require a valve replacement, once you put the valve, you not only fix the valve size because it's a prosthetic valve, and if it is a mechanical, it's not going to grow. It's never going to grow with the patient. And also, if it's a tissue valve, it is going to be degenerated very quickly. So we do have a problem. So one of the areas that you start thinking about if you want to innovate something, find out what is a problem in your practice. What is something that has been our community and the surgeons have been struggling with? And then you can start thinking about innovation. And if you want to do this, then you got to think more than just a one-sided thing. And I'll tell you a little more about that. So when I started looking at the expanding valve strut, and that is a valve that will expand and grow. So there is two parts of the equation. An expanding valve is that it grows, or it actually expands, or it grows, it pulls out with the tissues. So when we started having these are some of the problems that I encountered when I was thinking about it. The difficult to assemble without bending. So these are the struts. The metal is distorting. And this is something you have to think and work with engineers, and it comes apart when it puts together. So all these little things that are important to decide upon with engineers, but this is what you need to go to with the engineers. They have to give you back and forth a feedback on how you can start innovating and you putting these devices together, where you and you know, the engineers look at designs and metal types, but you're the one who's going to work with them and tell them where you're going to put the holes, where you're going to where you think that the maximum stress will be, and they will be able to give you some feedback on how you can eventually get to the expanding valve. So this is my pattern, which is the expanding valve, and I'm hoping that this will be implantable in animals in the near future, and hopefully in humans soon, God willing. Other areas that we talked about of how you could innovate. We are always faced with these complicated redo operations that sometimes you know that it's going to be a disaster going in after redo. The aorta is stuck to the sternum and you have an aneurysm. And what are you going to do with this? And most of the techniques that are used are short of having really a nightmare or a disaster. And a lot of surgeons would just say, just leave it be and let the patient die God's death. But there are ways of actually innovating and thinking about every case. So innovation does not always have to be a new device or a new procedure. You need to innovate and be thoughtful in every case that you do before you do the case, because every case has a different ways of doing it. And I personally always run through the case before I do it. I look at imaging very carefully. I run in my mind what I'm going to do. And more importantly, I do the huddle. I talk to my team before surgery, before even the patient is anesthetized. So I talk to the nurses, I talk to the technician, the perfusionist, the anesthetist, and everybody in the room. This is what we're going to do. These are the instruments we're going to need. These are the disposable that I'm going to need. I want to make sure in my OR there is the size of grafts I want, the size of homografts, the size of valves, the size of cannulas that I want. All this stuff have to be there. The last thing you want is you get in to do a complex operation, and all of a sudden you find that some of these are missing. And it is frustrating, and it could be actually detrimental to the patient outcome. And that's why you got to think and imagine. So this patient is, give you an example of a new application of an existing technique or devices. So this patient has had 6 previous open heart surgeries, came in with heart failure, severe mitral regurgitation, atrial flutter, and fib with hemolysis. Now, these are the previous surgery. 1 month had an aortic valve commissurotomy, then at 2 years root enlargement with 20 millimeter mid-hole valve. 2 days later, revision of the aortic root. 4 days later, AVR with a 19 millimeter St. Jude valve. Then at 6 years, had mitral valve and aortic valve dacron patch with replacement. And then at 11 years, had redo AVR cornerostan with a 25 St. Jude valve. Okay, so many operations and patches. So what's happening? He has reasonably good function, mildly dilated right ventricle. But the problem is that he had right heart catheterization, which showed that the wedge pressure was 38. The index was borderline. The QPQS, he had a shunt of 2-to-1. And there was a high pulmonary vascular resistance. And this is basically the CT scan that shows that calcified root. And it shows also a communication between the aorta and pulmonary artery. So there is actually a fistula between the aorta and the pulmonary artery, which was secondary to these previous patches in the ascending aorta. The actual patch is probably, or the fistula is between the aorta and the right ventricular outflow tract. So patient had the fistula closed with a device. The problem that the symptoms improved a little bit, but there was thrombocytopenia, and there was also, because of the hemolysis and the device that was implanted, and the patient became back symptomatic. So, and this is basically what it is. The CT scan shows that large fistula. You see now as we come now, and you see that huge communication between the aorta and pulmonary artery where this highlighted calcification is. So the patient needed to have a proper plan. 7th sternotomy, repair of the aorta pulmonary fistula, and a mitral valve replacement with root and ascending aortic replacement. So you want to think about how you're going to get in. So the innovation is not only something that is something new that you haven't done before, but this is what makes you a better surgeon and a safer surgeon. This is the stuff you start thinking in advance. How can I get in, safely do the operation, execute it in the best way? And this is what we have developed. So cannulate the right axillary artery or subclavian, whatever that area, in the right infraclavicular region. Cannulate the right internal jugular for retrograde coronary sinus perfusion cannula. Sometimes we actually put in a cannula in the IJ to drain also the pulmonary artery, and also we put in an endoaortic balloon from the groin that comes back and occlude the ascending aorta. Therefore, we can actually get in safely into this with a sternotomy, occlude the aorta, give cardioplegia through the retrograde even before splitting the sternum, and safely open the sternum and dissect without having a problem or a disaster and then do what you have to do. These are big operations, but this is where you show some excellence. So some innovation on how you get in. Once you do them more and more, you get better at it, and you get the results better than others, and you can actually get a surviving patient. Other innovations in surgical procedure for or new techniques. So I have also knew from the literature that distant pulmonary veins that drain into the SVC or IVC without a septal defect has a problem. They always have issues with you cannot connect them. So these are not total anomalous pulmonary venous drainage. These are just distant veins like scimitar syndrome, or veins that drains into the SVC. They drain to the right side of the heart, and there are no septal defects. The problem is the left atrium is small and far away from these pulmonary veins. So I've devised a technique that can be used to get these veins back into the left atrium. This is a depiction of this this scimitar vein. So this is, as you know, the vein comes down and joins the IVC. Here, the technique is basically dividing the scimitar vein, splitting it open, attaching it to the retro or the posterior pericardium in situ, then making the anastomosis to the pericardium, and then rolling up this pericardium in front of it, thereby creating a very large connection between the scimitar vein and the left atrium directly outside the IVC. The previous surgeries or techniques used to use the technique of intracaval routing, and every time, because either you get an IVC stenosis or you get scimitar vein stenosis, because the IVC is not big enough to be split into two. So these baffling techniques for the scimitar have failed, and that's why this technique takes away, you don't take anything from the IVC and you create a different channel for this scimitar vein to go into the left atrium. So this is basically a depiction of that procedure. Let me just show you how they look here. Basically, I've just jumped it. This is the vein being divided. This is a superior vein that drains into the SVC. So the left of the head of the patient is to the left, the feet are to the right. So this is a vein that is an anomalous vein that ended up opening into the SVC without a sinus venosus ASD. So the vein comes out, gets sutured to the pericardium in situ. And then if you'd imagine, this is the hole in the left atrium we're creating. This is the IVC. And then we're going to roll in all the tissues. This is the autologous pericardium. The phrenic nerve has been removed out of this area. And this is done before the pericardium is being utilized. So now I'm rolling in the autologous pericardium while it's in place. So that creates a huge channel between the pulmonary vein, the right upper and right middle pulmonary veins that will drain eventually to the left atrium. I'm just going to run quickly through this. And now I'm just completing this behind the interatrial groove. And this is a patch that will be used to close the hole in the SVC where these veins came about. So these were excised from the SVC, and now we just, you see how high it is? It's very high in the SVC. So there's no way you can split that SVC into two channels where you can actually do it without narrowing either the pulmonary veins or the SVC. So this technique of in situ pericardial roll can be used not only in scimitar veins, but also in, so this is how it looks when it's done. The SVC is wide, big, and open. And you see that channel in the back here. These are where the pulmonary veins that came out from this side and now draining directly into the left atrium. And this is how it looks with the CT scan post-op. Another area that there was a big problem with, and there was no solution to it actually ever, which is called what's called the transeptal course of the left main coronary artery. So the left main comes out of the right. So this is the right coronary artery. There's no left main. It comes out from the right coronary artery, and then it courses inside the septum behind the right ventricular outflow tract into the septum, and then it divides laterally. This used to be always treated with bypass surgery. Obviously, bypass surgery doesn't work. Why? Because you have competitive flow. And that's what a problem. So all the grafts will fail. These are the longest intra or what we call myocardial bridges that you could ever have. So what is the solution to this? It sits inside the myocardium, inside the septum, as you could see here. And when with activities, the septum will collapse on them, will shrink them. And that's why I was thinking, how could we go in? Obviously, being a congenital surgeon, knowing that I could entirely take this pulmonary valve out. And what tipped me over is that when I saw the CAT scan, the amount of muscle in front of that left main is very little. It's only a few millimeters of muscle. Not that it's very thick. So I thought if I open this right ventricular outflow tract from the front, I will see this left main that is coming out of the RCA running in the back behind the RVOT and be able to unroof it. And that's exactly what happened. So I dissected this, opened the right ventricular outflow. The question is, how can you resume continuity of the RV without compression? And the only way I would think about is to bridge that with autologous pericardium, where there's no contractile tissue in it, give it ample space and reconstitute this. So this has to be an entire a tube. And this is where this patch, so this is basically a depiction of that left main that has been unroofed. This is the pulmonary valve removed, and all the muscle has been divided. And then I bridged it with autologous pericardium. And this now is started to kind of be known by the Najm procedure, where, and this is basically a depiction of this operation. So I stop here. I see why I was talking about when I saw this angiogram and I saw this the CTA and I saw this, I thought, the septum is behind it, it's not in front of it. So this is the muscle which is causing the ischemia. And if I divide this, then I will actually take this away. I'm going to run it. You see how nice the left main now? And this is how it looks like. So these are also techniques. Now, this is a way of integrating or linking existing techniques with a new concept, the creation of a new paradigm. This is what I created and called the ventricular switch. So I coined this term. There hasn't been an existing term called ventricular switch. It used to be called an atrial switch. There you have an arterial switch and an atrial switch, but you do not have ventricular switch, and that's what I've created. Very quickly, the concept goes into those what's called unseptatable hearts, where it's too complex to septate them. The surgeon said, okay, we're not going to septate them. We're going to just put them into a univentricular repair where we're just going to do a Glenn and a Fontaine, and that's about it. And I would argue that is not a good. You're actually throwing out a ventricle that is of good size and function, and you're throwing it away of the system. And I was proposing, and I proposed this ventricular switch where you create what's called a CCTGA physiology, which means that the LV pumps to the lungs and the right ventricle pumps to the body. So basically we create a congenitally corrected transposition physiology. And the reason why is this, that the survival after the Fontaine is not so good. And that's why you got a problem. You always have to look at the outcome, look at the long-term outcome, look at the need and find solutions for what is a long-term outcome would be. I don't want to go into the details, but basically the Fontaine have bad outcome. And when they fail miserably, and they're not even suitable for transplantation. So what the theory behind it is that the LV can be beneficially harnessed, even if it is moderately hypoplastic, to be used as a subpulmonary ventricle in a circulation. And the aorta is committed to the right ventricle rather than to the left ventricle. So basically, we're converting it into a CCTGA physiology. And you know what? Even if that right ventricle fails as a systemic ventricle, we still have the option of transplantation. We have the option of assist devices, and all that is available to heart failure. But when the ventricle fails, you still have all the organs working. So the kidney, the liver, and so on are working, compared to a single ventricle. When Fontaines fail, they fail miserably with also liver and kidney failure. And these are the people who are the conduits for this. And what I did, I have access, and I'm sure you do also, to 3D printing. So I start looking at those hearts, and I look at the inside and see how I could innovate something new. So use some of these newer technologies. Now, this is 3D printing, but you could also use some virtual reality, VR, what they call VR. So you could look at the heart with these 3D glasses, and you could see the inside of the heart. So all these technologies are available, and you should have access to them. And I'm sure there is something in some of the programs in Saudi Arabia that will have that. So this is one of the concepts that I have created. So this patient is 40 years old, has had 2 SVCs, IVC and hepatic veins drain into the RA. He's got a common AVSD. He's got a what we call ill malposed anterior aorta coming out of the right ventricle, and then an LV that has a connection to the left to the pulmonary artery. So I ended up septating, translocating, very complex surgery. But at the end, if you look here, the hepatic veins and the systemic veins goes into the left ventricle, and the left ventricle is connected to the pulmonary artery, and the pulmonary veins drain into the right ventricle. So the pulmonary veins drain into the left ventricle that eventually go to the lungs, basically. So that's what it is basically making the left ventricle as the subpulmonary ventricle, and the right ventricle becomes the systemic ventricle, which pumps to the aorta. And this is really a depiction of that surgery. I don't want to bog you down with these techniques. This is a valve that I use conduit. I do it basically on the back bench. I put a graft in, and I put a valve in the middle of it, and that's it. These are the best grafts that I use because if I wanted a long graft, there's no way I could use a homograft or something. So these are areas that I innovate of how I could do the best. And here I'm just basically doing that. What you saw, this is the common AVSD division. I'm going to run quickly through this operation, but you see how you innovate on the inside, close the VSD. So now, as you see, the VSD is closed. The common AVSD is the common valve is split. This is the atrial septation, or what I call atrial conversion, because it's not really an atrial switch. Now the hepatic veins and the systemic veins drain behind, which means they're going to go to the left ventricle. And the pulmonary veins are going to be connected to this right atrium and to the right ventricle, which connects to the aorta. So it'll be like a congenitally corrected transposition physiology. Here is the left ventricle to the pulmonary artery conduit. And this is the valve that I've created just before. I cut it so I can cut exactly where I want. This is connected to the left ventricle now. And then eventually it is, I translocated the right SVC to the left SVC. Quite complex. Having said that, the patient came out with a saturation of 55 and left the hospital with a saturation of 95. So this is a huge achievement, which is much better than putting this patient into a, this is when the operation is finished. So these are the different stages of the operation, and I won't go in it. This is published. You can find it in Journal of Thoracic and Cardiovascular Surgery. And this is how these nice conduits that I use long enough, but has a valve in it, I implant the valve wherever I want in the middle of that graft, and then I put it in. So the final operation, and I will show very quickly this. This is submitted to the STS. You'll see it. I'm sure it's going to get accepted. But this is basically the fetal surgery that the whole world heard about it. I'm just going to run this quicker. Sorry. So now with all these innovative procedures, the question is, do you actually believe in inspiration theory of creativity? So is it actually true that there are people who are inspiring and they are creative and they are different? And the answer to this is no, it's a myth. Anyone can have a flash of a genius. Any one of you can be that person, or can be me, or can be even more than what I have achieved. And I'll tell you why. There's a pattern of creativity. Moments of brilliance are not sudden. They are a product of many hours of thinking and training. Nobody else can do this except yourself. Nobody else can think for you. Nobody else can start looking at where the problems are and finding solutions for them. You got to spend the hours to think about something new that you can add to your specialty. This book, I'm sure you've all seen it, The Outliers, and talks about people who are on the outliers, this is by Malcolm Gladwell. I'm sure you've read that. It's not a new book. And it's the famous 10,000 hour rule. And I think it's just an average or just a number. It could be 20,000 for somebody and 30,000 for others and 5,000 for others. So it is an average, but it's basically you really have to put the time and the efforts to be there. It's not going to happen by chance. Don't think that people who've come out with some ideas just came out of nothing. And when I hear and see in media, to be honest, that somebody who is 15, 17, 20, 25 years of age is a genius, I actually within me. Not that I actually denounce them or I think they're not. Most people who have shown incredible intelligence do not make much in their life. They actually don't become amazing performers. And this has been studied, as a matter of fact. So the talent and creativity is not proportional to the IQ of people. So, and I've always, you probably heard that in my interview in Ramadan. I don't think that people are very different in terms of, even if there are people who are smarter, if you spend the time and the efforts to compensate for this, you will bring something new to where you are. Your limitation is yourself only, not the people around you, not the systems around you. It's you who are going to make the difference. So don't think that those people who have come up with incredible ideas and incredible procedures are different than you. So you need to spend the time and the efforts to think and improve on every stage that you have, rather than just wait for this to happen. So creative genius is a social phenomenon. It's not a truth. Einstein was never known to be a genius when he was alive. It's all actually, everybody didn't even trust his theories. He published them, obviously, and became truly the amazing genius of the 20th century. But at this time, he wasn't actually known to be as such. They thought sometimes he's actually crazy. So what you need to be, it's always, genius is after the fact. So when people achieve so many things and work hard and achieve so many things, people think that they are. But reality is they've spent the time and the efforts. And this is actually a true study, and I really want to apologize for this depiction, because it says men and women, but they did a study in the UK, and they looked at the hippocampus, and they wanted to see whether we can develop and change our brain or not. So they looked at school bus, where the bus goes exactly the same route every day for months and months and possibly years, while the taxi driver, if you've been to London, UK, you know how difficult the streets are in London. And every time the taxi driver, before Google, obviously, they had to find ways of getting to where they want to go in the best way without getting into traffic, without getting into long ways and so on. It's very difficult. They just looked at their hippocampus and they found that they are different. And simply because you can influence the brain. So nobody is just born with something that you're going to live with for the rest of your life. You can change your brain. You can change your brain by the way you think. You can change your brain by the way you start approaching things. So it is not, oh, that guy is better than me, oh, that lady is smarter than me, and so on and so forth. No, you actually can change that. So the fact that you haven't got it now, it doesn't mean that you can't have it in the future. And this is a true study that shows that you can actually change your brain structure, let alone that you can change your brain function. So the creative curve, and this is where, when you start thinking about it, there's a book that that is, if you look it up, it's there. It's called The Creative Curve, and how you develop yourself. It's easy to read. You could put it as an audio. You can listen to it, and you could read it. And these are the different stages where that you should find something that is familiar to people and they are preference. And we're talking about, obviously, this book talks about general creativity, but we talk about surgical creativity. So you want something that you want to improve on the patient, and you want something that other surgeons can do and become familiar with it. And what you want is, when you get to the point of cliche, which is in the middle, you don't want people to lose interest in it. You want to continue to take it up by newer ideas, developing the techniques. And obviously this book talks about corporate structures, talks about how you develop the idea of the social media and how you continue to evolve with that. And so people continue to be interested in the product that you're doing. In our way, in our area and domain, it's more about surgery. Now, if you look at this adoption curve, do you want to be one of the innovators, the small amount of them, or you want to be an early adopter of new innovations, or you want to be the early majority, late majority, or laggers? Obviously, a lot of things can impact your decision about this. And you want to make sure that look at these newer innovations, because if you start looking at the new innovations, you likely yourself become an innovator. Why? Because you're going to start changing, because maybe the original innovation, one of the surgeries that I've innovated, maybe to you is not as good. Maybe you want to improve on it. As a matter of fact, some of the surgeries, I have started changing them themselves because I think the results can be improved by the next iteration of the innovations. And that's why you want to become an innovator or an early adopter to make sure that you become an added value to your specialty. So if I could bring you an operation which has a 60% mortality, would you accept that? The chances obviously you would say, oh my God, this is too hard. This will never be going anywhere. So if I do an operation that has a 60% mortality, nobody's going to accept this. If you look at historically, the arterial switch operation, which was created by Jatin in 1981, had a 60% mortality for transpositions. And you know what? This is the only operation we do now, which is arterial switch operation for transposition. And you know what the mortality of it is? Is less than 1% in good hands. So this is the transformation. Yes, there have been 30 or 40 years difference of improvement, but it still is called a Jatin procedure, even though that it had a 60% mortality at the beginning. This was studied by Marc Delaval, and I think it just proves the point that when they went from the sending or what's called the HL procedure to the arterial switch procedure, the mortality has gone substantially higher. But with time, it got better because everything gets better just as we go and as we improve our techniques. So the learning curves in surgery is not only upon the surgeon, him or herself. Learning is about the surgeon, the specialty community, as well as the institution. And I have to say, if I share with you that in the last 6 years that I have, 6.5 years to be exact now, that I'm working at the Cleveland Clinic, when I came in, I thought, the most important thing is, what am I going to add? I am working among a very competitive environment. Everything is transparent. And the results, as you know, is published, there's public reporting. It is not only good enough to do good surgery. Good surgery is a given. So being involved, being engaged, doing good at what you do is a given. That is the basic standards. What you need to do and think as a resident or as an early career surgeon is what I can do more than others. What others cannot do, I want to do. This is how you improve. And that's where I was thinking that I got to think about outside the box. I got to improve and add to what everybody else is doing. The institution is important, but also your role is to improve on what is in your institution and demand better care, because at the end of the day, you're going to add not to yourself. The bottom line is you want to improve on your patient care. And that's what should be your best argument with the administration. So what you want to do is you work with a high volume, low risk heart surgery units. So if we talk about the elements of creativity, there are 3 areas. The subject matter, which is the domain. You got to know your area. You have no excuse if you don't know your area. Getting science now is at your fingertips. It's in your phone. There's no way that, or there's no reason whatsoever that you spend more time in social media rather than getting to know what you should know and improve your future. This is what it is. This is the time you need to learn everything. You can't go into an operation as a resident and you haven't read the exact notes. You've seen all the details of the history. You've seen all the images, and you've read about the operations and know about the complications and the possible ways of doing the operation. Don't waste your time in other things which does not change your future. This is what changes your future. You got to be the subject matter expert in that area. That's your domain. Element 2 of creativity is you got to work with the gatekeepers. You got to find the gatekeepers to make you creative. So you want to work with innovative surgeons. You want to work with surgeons who are truly, if they can be available to you, sometimes it's difficult, it's not so easy. If they can be available to you, work with them, seek the discussions with them, intrigue them on questions, because this is how you become creative. This is how you become inquisitive about everything. And the third element is the individual, which is yourself. You have to persuade people with who you are and what you're coming with. You cannot come with a new idea that you haven't vetted and you haven't read and you don't know all the details about it. This is how you become creative. Some other areas of flow of creativity. This for advanced creativity. This has to be something that people will consume, your colleague surgeons, when it becomes. It's got to look familiar to them. That's what they call imitation. It's not you're making an imitation, but it is familiar to the people you talk to. It's not coming out of the moon, so they can accept it at the beginning. And you have to have creative communities that you surround yourself with people who are like you. Don't surround yourself with people who are not like you, because they're going to take you down and they're not going to make you progress through your life. And then you're going to do the same thing again and again until you keep thinking about it, until you come with newer ideas. So innovation and creativity is a process. It doesn't just come out of the blue. Some people say, well, these are the best ideas comes when you're taking a shower. Yes, it may be, but it is a result of many thousands and thousands of hours that you've spent. The concept, or what they call the aha moment, comes in from a prepared mind. It doesn't come out of vacuum. And then it matures in the heads of the innovator. Then you digest the idea, and then you simplify it, you synthesize it, and you integrate this in assembly, and then to do the iterative feedback. Now, what are the impediments to surgical creativity? Why some people are not creative, and what are the environments that do not make you creative? One thing for sure is the individual confidence. Can I do this? And I want to give you and share with you some of the really insights that I have through my career. People will see you through your own eyes. I have said this to many people who've been around me. And I tell you, if you have the slightest inconfidence in yourself, people will see it. So for you to become confident, you gotta read and understand exactly what you have, and people will trust you for what you have. So if you lack confidence, and you should acquire, this is not something that is everybody is born with. You become confident when you know your stuff, okay? When you know it well, you will become confident. There's no doubt about it. Another area that is impediments to surgical creativity is the work environment, the culture of creativity. And I have to say that in certain areas that I work, when people think that others are better than us, this is where the problem happens. Is when you can think that somebody else can do something better than you, then you always become the second or the third or the fourth, or God forbid, maybe the 10th or the 100th. So always think of yourself as being the leader and you want to do what others cannot do. Automaticity, which means that, oh, we do this in the same way every time. Well, if you do this every time the same way and you have a 10% possibility of problems, maybe if you change it, you get 5% possibility of problems. Maybe you need to change. Maybe you think about something again and again that you use all the time and you want to change it. The last thing is public reporting. Obviously, this is more in the United States, but I think it's also important everywhere. And I have been calling for a national cardiac surgical database all through my life in Saudi. And here in the United States, its public reporting becomes an impediment because your outcome is related to this. And if you do something new, people say if something goes wrong with your operation or with your innovation, then it's going to be counted against you. And that's one of the reasons why people are worried and afraid. But once you become confident and you know that you're the last stop, you can do this. So, is there a place for innovation? I think it is imperative in all of you to innovate. And I can tell you what I am doing and what the cardiac surgeons doing now are going to be different than when you will be doing later on in your life. And in 15, 20 years from now, completely different. Now, in the last couple of slides, I just want to talk a little bit about the cardiac surgical training because I was asked to do this. And it is important for you, and I put this one single slide on the cardiac surgical training, and I'm happy to open it up after that for discussion. And please don't hesitate to ask questions towards the end. You need to see as many cases as possible. The 10,000 hour rule, the 10,000 cases, the 10,000 patients you see, the 10,000 clinic patients you see, everything goes in thousands and thousands. I couldn't have come up with newer ideas or with newer techniques if I haven't seen thousands and thousands. And you know what? Our brain is so amazing. Because every time you see a patient, there is an algorithm that gets stored in your brain. That algorithm gets called into action with the next patient you see without you knowing. And that's why I think the huge difference between artificial intelligence and human intelligence. The human intelligence is unique, is that it's very adaptive to the different environments. So the more you see, the more you have in your brain of how you can deal with these, whether it's surgical catastrophes, whether it's clinical patient care, whether it's decision-making, all this comes into your brain, gets stored, and gets called in. The other day, somebody was asking me, I was closing the right atrium in a certain way. And he said, where did you learn this? Because this looks easy and it's lined up and so on and so forth. I said, I can't even remember. Did I make it? Did I learn it? I don't even know. So all this stuff. So you want to do the volume. Got to do as many cases as possible. Other areas in the surgical training, number of surgeons needed versus programs. This is really an integral part, not in your hand, but if there are too many trainees for too little cases, then it's a problem because you're not going to see enough. And if there are enough programs with larger volumes, then you want to see as many cases as possible. Engagement of program directors. You cannot have a program director that will not see you at any time you want and is not in contact with you every week with every education session that you have per week. It is engagement. It's a commitment. And these program directors, if they're not engaged, if they're not following you, you're not going to get the training you want. Program directors' engagement is integral in flourishing your training. Engagement of residents. You and your colleagues have to have that circle of knowledge. You got to actually discuss cases together, discuss complex cases, share with each other what you've seen in one center versus the other, and how can you share this knowledge either in a group or something. You may have that already now. It's so easy to do it with
different social platforms, but it is really important to communicate. Oversight of programs. So the Saudi Council should be looking at the programs and evaluate them. And this is by 360-degree evaluation. So I get evaluated at the Cleveland Clinic by the residents, and it doesn't go to the enterprise. It goes to the ACGME, which is the body like the Saudi Council, where I get evaluated as an educator. Am I a good or not? So it's not only the program director that gets evaluated with the program, the actual surgeons, each one of them who is registered in the program, have to be evaluated. And you know what? If the teacher or that person is not good, or that surgeon is not good in education, the program gets a probation. If they do not get and go, so although I'm not the program director, I get evaluated. And if my evaluation is low, the program director, my chief, will talk to me that, our program is in probation because of you're not engaged in teaching fellows and residents. I have to teach them. So it's a feedback mechanism. And obviously the public outcome of results, which means that if residents fail their exams, this is really bad for the program. And you know what? It gets published. So transparency in the outcome is really important. So you can't just duck this under the carpet. If the residents in the program do not pass their exams with high marks, there's a problem with the program. It's not only the residents' problem. It is upon you to work hard and learn. But the reality is you have to be in a program that cares about you. The last thing I want to talk about is the Hani Najm Global Scholar Award, which is through the American College of Cardiology. You probably heard about it. So it is for an early career. I don't know if there are early career in this group or not, but it is for a finished trainee, somebody in their first 5 to 7 years, cardiac surgeon or cardiologist who are just starting their career. And the reason why I picked it to become early career rather than residents is that at that time, the return on investment of the person coming is much higher. So they come in 1 month with at the Cleveland Clinic if they are surgeons, then they are with me. If they want to go to the adult side, they are also with me, or with another surgeon in the adult side is fine with me. Or if they are a cardiologist, then they join the cardiology team. And then eventually they go to the American College of Cardiology annual meeting, they attend that. So this is all sponsored, and the website is there. If you look at the ACC, I can send you the link. There are ways of getting into that. And the last thing, I want to invite you to come to my meeting. This is my 7th meeting since I came to the United States, which is the 7th annual Advances in Congenital Heart Surgery. This time I'm doing it in Orlando in next February 16th to 18th, 2023. It's congenital, it's transposition of great arteries, the master class. We're doing this with the University of Florida in collaboration, and this is going to be a great meeting. This is my 7th one, and it's been really getting a huge traction in the United States in the congenital environment. With that, I will stop, and I would finish with this: living in possibility and abundance rather than limitation and scarcity. This is the best way of thinking and defining creativity. Thank you.
Thank you, Dr. Hani, for this mind-blowing, we can say, career-enhancing and stimulating for us as residents, the talk. Really appreciate your talk, and thank you. I'd like to start probably with a question regarding the innovations and amount of hours. And I understand that you pointed out that a number of hours need to be spent, differ from person to person, career to career, and but don't you think that with generations and our generations, probably the next generations, it will take us even more time to reach that level? And is there a room for innovation at a resident level, or is it really in early career with many techniques being developed? One might think we don't want to reinvent the wheel. We have to look at those many techniques, understand them, grasp them, and look at the results, and then think about innovation. What do you think of that?
Good question. So your innovation is not going to come now. You're preparing for your innovations. What you need to think about is, where are you going to be 5 and 7 or 10 years from now? Not now. It's not something that, as I said, is going to be a flash of genius that is going to come out of you. No. You actually have to work hard now to prepare yourself in 10 years from now to be that person. Because it's not just going to come in like this. And it's nice to think. I'm not discouraging you from thinking innovatively. No. And I'm not saying that you shouldn't think differently. As a matter of fact, I've always been like this when I was at your level. I've always thinking. I remember about a technical thing. I was helping an abdominal aortic aneurysm, a vascular surgeon, and he kept putting the same suture again and again. It keeps bleeding and bleeding and bleeding in the back of the aorta with the graft. And I just immediately realized that he is missing the point. What he's missing is that there was a longitudinal tear in the back of the aorta, and he's still trying to stitch that aorta to the graft. So I said, can I take that needle and do another thing? And I just put the plaginated suture transversely, be it blindly in the back of the aorta below the anastomosis, and that stopped the bleeding. And I was resident at that time. So this is one way of thinking about it. Always think differently. But what you're trying to do here in your training is total engagement, total thinking. You're dedicated, okay? What are you going to be in 10 years from now is what counts. Is the road to be there is what counts. It's not about where you are now. What you're doing now is building the foundation for the future. And that's what you should be thinking. And you know what? This is the time to do it. When we're young, when you got the time, and you can spend the time and the efforts doing this, because that is, I see 45 people in this platform. How many of you are going to be the innovators of the future? Why not you? Each one of you think, I want to be that person. Because that reality at the end of the day is what you want, is truly to become that person in the future. Other questions?
Well, thank you. Any other questions?
Please unmute and ask the questions. Or if you want, write it on the chat.
May I?
Yes.
Okay, my name is Tasneem Balkhiyour. I'm a resident in King Faisal Specialist Hospital, Riyadh. Thank you for this enlightening presentation, doctor. My question is, you have many inventions for these procedures. It's a new innovation, and it wasn't done before. How do you know it's going to be successful? And how do you have the discussion between the patients and their families regarding the procedures? Thank you.
Very good question. Absolutely brilliant question. So you bring in something new. As I was mentioning through my talk, we have a problem. You got to identify a problem. I mean, you can't have something really successful and start improving on it. What you want to look at is where the problems are, because this is where you can change. And if I talk about part of a completely different concept, why am I actually in Cleveland to start with? I didn't want to actually come to Cleveland. You know all this. You probably know my story. I didn't even apply for the job. I didn't want it, okay? It came to my doorstep. But when they invited me, because they invited me to improve, I saw a problem. I saw that they've got problems with doing surgery. I knew that I could improve on it. See, every time you want to come with something new, you want to actually show that you can do a difference. You can change things. And this is why I came and I accepted this, because I knew that what they need is better surgery. And I know I could do that well. So when you want to innovate something, look of the areas where there is problem, pick that area and improve on it. So that's in terms of the area that you want to innovate in. The second question you had is, what do you tell your colleagues and what do you tell the patients and the family about this? So about your colleagues, first of all, your colleagues have to trust you. And that's why I was saying about the creativity, is that you have to be a persuasive individual. And that person is not going to come out of blue. That personality is you. So what I'm saying is, you cannot be somebody who you're not. So you're the one who's going to have that trust in the people. So, and why I'm saying it's going to happen in 10 years, because if you're not that trustable person for the first 9 years, you cannot expect that at year 10, people are going to trust you all of a sudden. So basically what you have to have is your career has to be built when you create yourself. You got to create that individual that people, when they talk to, they trust. And that's why you can convince your colleagues, this is a problem, this is the procedure, and we've got problems because the outcome is not good. This is what I think we should be doing with the new thing. Now you've convinced your colleague because they trust you as being a trustworthy person and persuasive. Now, when you go to the family, is another thing. Again, this is what I do. And I did this, by the way, there's another 2 or 3 procedures that I didn't bring in, but they will be published soon. Is I came in, I went to the family and I said, listen, this was on a patient with pulmonary atresia, intact septum with the RV-dependent coronary circulation. And I said, listen, the outcome is like this. The chances of heart transplantation and failure is like that. But I want to do this procedure that may avoid being in an assist device or transplantation. And I explained to them. And obviously, you need to pick the right parents, the right family, and so on. But sometimes, so what the first question is, have you done this, doctor, before? And I said, actually, not me, not anyone in the world. You've seen the fetal surgery. You know that fetal surgery, I had a call of 45 minutes the night before from my colleague trying to convince me not to do this fetal surgery. Why? Because he didn't feel that he would know the outcome of it. The next morning, I still went ahead and did it. Why? Because first of all, I trust myself because I know that I have done this procedure after birth. Secondly, I knew that the fetus is going to die if the operation is not good. So the alternative is worse. So this is where you pick your procedure, pick where the problem is, become that individual. You have to be that individual that is trustworthy of everybody around you. And that is upon you. Nobody can give you this. Nobody can take it away from you. This is how you're going to become in 10 years from now, is that trustworthy individual. And then you can be transparent with the family and tell them, this hasn't been done. I want to do this. And the outcome is expected like this. I believe that when you become like that, I tell you, and I have worked with so many smart and not so smart parents or families, okay? And I tell you, when you come with them honest and you're persuasive and you're confident of what you do, they will accept it.
Thank you, doctor.
Other questions?
Hello, Dr. Hani. This is Ayat, cardiac surgery resident. I'm working at King Faisal Specialist Hospital. So I just want to share my story. So one day I was working with my senior. I started opening the patient, then cannulating and so on, as usual, you know. And then one of the anesthesiologists was like standing there in their area and started talking, telling a story about one cardiac surgeon. And one day his senior told him that you cannot be a surgeon. Surgeons are surgeons. So they were born to be surgeons. So they are smart to be surgeons. And you cannot just come and say that I'm gonna learn. It's not about learning. It's something that you are born with. So I kept silent, and my senior started talking to him. He told him, no, that's why we have training. Trainees are here to learn, so you can learn something new. He said, no, Arabic doctors are stubborn and they don't want to listen. You have to listen to somebody who's senior than you, because they know who are the surgeons. They have character, they have personality, they have, so they are similar, you know. Well, I agree somehow, because some are fit to be surgeons, some are fit to be medical doctors, but I don't totally agree. So what's your opinion about this?
Very good question. First of all, I believe that these statements are inaccurate. And truly, yes, I do believe that there are people who are born with certain gifts, let's call it, okay? But everything is actually can be learned. Almost everything can be learned. And that's why the only difference between the people who have the gift and the people who do not have the gift is that they need more time to learn to get to where they want to. See what I mean? Is that gap, the gap, you can bridge the gap with few more hours. That's the only difference. So what I'm saying is, yes, maybe they are, let's talk about leadership, which is, people think, oh, they're born leaders, and they are, if you're not born leader, then you can't make it. No, there are people who are, yes, born leaders, but they're never a 10. They can go from 7, they're born with a 7, they become a 9. If somebody is born with a 6, they educate themselves, they become an 8, they spend the time. So what I'm saying is, everything can be learned as long as you consciously realize where you are or where you want to be. So yes, there might be innate nature of things. Some people are more technical with their hands, they're more intellectuals, and so on and so forth. But if you choose, and all of you on this webinar, I'm sure, are very smart people, okay? Once you choose that, you got to make it work. So you got to spend the time and the efforts on yourself. You got to know where you are, where you want to be, and you work on the areas of your weaknesses. Every time I come out of surgery, I actually tell the fellow with me, and that's what I used to do, and I still do this until today. What would I have done differently in this surgery next time? Why? Because if I learn every time that I should do the next time something better, then my next operation is going to be better. And if you do this again and again, what's going to happen? You're going to perfect your operations. You're going to perfect your decision making. You're going to perfect your rounds in the morning. So every time you got to build on and experience and change it. And the best competitor is yourself. To yourself. That is, you always want to compete with yourself, not with anyone else. Because if you compete with yourself, the chances are going to get better and better to yourself. And that's what counts. At the end of the day, you want to get better. So compete with yourself. And I learned this. I don't know if you have the Peloton or not. Every time I get in the Peloton, which is basically a bike that has a program, and you get on and you do X number of minutes, whether it's half an hour, 45 minutes, 1 hour, and you exercise and you achieve a certain target. And the next time I don't achieve it, I say, well, what's happening here? I'm not even achieving my own best. So I want to beat myself. So every time you want to improve on yourself, you beat yourself. And every time, if you beat yourself every time, you're going to get better with time. So going back to your question, this is partially incorrect. I think all of us are there to learn. Nobody is born learning everything. You have to identify your areas of weaknesses. I tell you another area of a weakness that I had. I graduated from, everybody knows, from King Saud University, and I have graduated very weak in statistics, and I've realized my weakness. I didn't even know what a t-test and what is a continuous variable for nothing really. So I decided I'm going to finish this. I can't live all my life not knowing this. So I took a master's degree. So it's your decision. There are areas of weakness that you realize that you're weak in, and it's your decision. If it's technique, you know what? Do whatever you want. When I rotated early in my residency, I used to go to what used to be the Shemaisi Hospital, which is now it's probably called the King Abdullah Center or Hospital, Ministry of Health in Old Riyadh. And I used to do surgeries there like crazy because at that time, they just gave the residents whatever they wanted to do. I used to do AV fistulas, and I did, all these vascular anastomosis and so on and so forth. What I'm saying is identify your weaknesses, be honest with yourself, improve on it, work on it, and get better. Don't listen to anyone who's going to actually put you down of, this guy or that lady is a surgeon, the other one is not. Everything is learned. The only difference you want is the difference of hours you put in. You identify what you want and you work on it.
Totally agree. Thank you.
Unmute and ask questions. Dullah, I'm not sure. Go ahead.
Assalamu alaikum.
Yes.
Thank you, Dr. Hani, for your time and your talk. I have only one question for you. As you, once you face a problem, that's what you listed before, and you will go through brainstorming. What's your own process of brainstorming, and also what's the step before you apply it to the patient?
So I assume your question is during surgery? Is that what you're asking for?
No, before surgery.
Yeah. So let's say I opened a reduced sternum and I got into the heart. Let's say this is the disaster. Is that something like this you're talking about?
Yes.
Okay. So I opened the sternum and I got into the right ventricle. So the question is, what happened? Why did I get into the right ventricle? Okay. I analyze every time. And we all have been into these situations, or you're cannulating even a fresh sternotomy aorta, and then all of a sudden you've got bleeding from your purse string. You got to know, what did you do? Were your sutures too deep? Were they too superficial? Did you make the hole bigger? Make it smaller? Going back to the right ventricle, did I look at the CAT scan and analyze the RV? Did I use the proper techniques? God forbid that it will ever happen. I have not got into the heart for the last, 4 or 5 years, and 90% of my practice is redo surgery. 80 to 90% of my practice. I use something called a roll track to elevate the sternum. I study every CT scan. So if the RV was supposed to be open and I saw it with the CT scan, should I have cannulated the groin before and decompress the right ventricle so I don't have to go on? And this is the stuff that I go through. And with time, when you do this again and again and again and again, your brain learns it. And what's going to happen is the next time you see the same image with the CAT scan, I never do a reduced sternotomy, by the way, without a CAT scan. Impossible that I would do this. So once you do this, your brain will tell you, this heart, you should go on the groin bypass before doing the sternotomy. This is something that's going to come. So that's how you look at it.
Okay, thank you.
Dr. Hani. This is first of all, I would like to thank you for giving us this time for your busy schedule. I know I have been bothering you for the last month to arrange for this lecture. I have two questions actually for you. The first one, do you think a resident being trained here in Saudi Arabia has the same supporting environment to be an innovative mind in the future once he graduated, or do you think that we have some defects in the system that need to be tackled?
Again, I think it's a great question. So I am not going to discourage or give you false hopes, but let me tell you something about one thing I know that people say, people who graduated from amazing universities like Oxford or Harvard, they are going to do amazing job versus those who have not. And obviously, this is wrong. It doesn't matter what university you graduate from. Now, this is undergrad. Now, for training, I think we have, at least, let me speak about Saudi Arabia, a place that I have seen most of the cardiac centers. And obviously, I've established for 16 years, 17 years before I came to the United States. I think there is enough material and training in Saudi Arabia that, yes, to become an exemplary cardiac surgeon. And honestly, I think there are some limitations. I'm not saying it's not, okay? Specifically, to be transparent about it, is that if I consider what is the difference between me now and me in Saudi Arabia before I came to the United States, I would say people look at me now as the final stop, and I am looking at myself, and I've always looked at myself as being the final stop in any patient. And that's why I'm able to innovate newer operations. People are expecting more from me because I work at the Cleveland Clinic. Now, I think it's very important that you become that person in your career that people want and trust you for who you are. And I would say this doesn't come over a year or two. So among the 40 plus people, we've lost 3 so far, with 40 plus people in this webinar, I would say there are people who are totally engaged and would want to be in every meeting, participate in discussion, and become that engaged person. You know, I think, if I deviate a little bit about this, just the social media thing and the phones and so on, you know, I think people go to meetings these days. Basically, they just want to go to meetings, but you look around, they're on their phones, texting or talking or chatting, or others, they're never listening to what everybody else. Don't be that person. Engage, get up and ask questions for every talk that you hear, because that's how you make a difference. This is how you get engaged. So be that person whom, when you are in training, you shine. When you are in early residency, you shine. When you are in early career, you shine. You got to shine in every stage of your life. It's not going to come by chance. It's not going to come by accident. You got to shine in and it's all upon you. And I tell you, I don't want to brag, but your evaluation should speak for yourself. Are you convinced and are you happy with what you're doing? You need to make sure that you shine among your colleagues. Okay, you want to do what others couldn't do. If people leave at 5 without looking at an X-ray that they should look at before patient get a cardiac arrest in the evening. This is wrong. No, you can't do this. You can't leave a patient with a chest tube removed and has a pneumothorax that could arrest by the evening. So something like that. So you want to do what others couldn't do or wouldn't do. And if you take that, I can tell you, you are going to shine and you will achieve something in your life. So you being in Saudi Arabia with the current programs available, yes, the answer is yes, you can, and you can be an amazing future surgeon that can change your surgical field. I can assure you that.
Thank you. The second question, do you think that it has become more difficult now to train surgeons in comparison to 30 years back? You know, this public reporting, we're doing surgeries with very minimal mortality and morbidity. So,
yeah, good question. Yeah, again, add to this, not only this, you are expected with a great outcome. And here, at least in the United States, also, there is a lot of transparency. So every mortality counts, and nobody is, well, yes and no. Yes, it is difficult. Yes, everybody is supposed to achieve higher outcome. But this is where mentorship is coming in, apprenticeship. Do you know, by the way, just so you know, do you know that 80% of complex operations I do, I'm assisted by another surgeon? Look around you. If your program do not have two surgeons helping each other, there is a problem. It used to not happen with me in my center at the National Guard. And I say, what I see at the clinic now is the right thing to do. When there are complex cases, two people are good, because this is where the surgeons help from each other. Definitely an early career and a senior surgeon. Now, for training, I would say, yes, you want to actually do the best. You want to make sure that you're not. Everybody is worried about outcome. They want to make sure that the outcome is good, and that's why. But that's not a reason not to train you. And that's why I said engagement is so important, not only from the program director, and from all the surgeons. They have to understand that is what is your right, that they have to be there. And I tell you, I have worked for so many years without having a training fellowship, except for the last few years when we started our program at the National Guard. And now I have to accept that the FEAST fellows have to be taught, and have to do all these cases, because this is how I learned. This is how I will leave a legacy and train other people. So the answer is yes, it is a little more difficult, but also there are a lot of technological advancements on virtual reality, 3D printing, that you can actually do the surgeries in labs and in printed hearts, as well as in animal labs. So try and create something that will compensate for this inability to do as many cases as you like to do.
thank you. So back to you, Abdullah.
Yeah, thank you, Lai. Dr. Hani, we have a question here from Amjad Bernawi. How it's possible to do a pediatric or adult congenital heart disease rotation at Cleveland Clinic as a resident for maybe 6 months with you in particular? Is there like any, for residents here in Saudi, any opportunity for a rotation at Cleveland Clinic?
Well, I mean, if you have the USMLE, that's what is the bottom line. There is something called ACGME accredited rotation and non-ACGME accredited rotation. So the ACGME is like the Saudi Council in America. So if you're in a training program which is recognized, which is going to lead to a certificate, this is where you'll be. But you can have a non-ACGME rotation. But before you have this, you have to have your 3 steps in UCMLE. If you don't have the 3 steps, you cannot touch a patient. And there's no point of doing a rotation, of surgical rotation, in a place where you cannot operate. So, I mean, you're going to be seeing surgery. You can come for observership, usually observership for 1 month. You can learn something from it. You need to be funded for observership and for the non-ACGME accredited, non-accredited rotation. You can come and join and see and operate. If you have the 3 steps, you can. And it's obviously it's not required by the program, it's required by the state. You can't touch a patient unless you have the 3 steps, the USMLE's 3 steps, so you can operate.
Thank you, Dr. Hani. Any other question? If I may conclude, Dr. Hani, with the last question, how do you I understand, like you must be spending most of your time at the hospital and between innovations, leadership, and running this huge and busy center. How do you find a way to for a balanced life between your career, family, social life, and everywhere? And I don't know. Me personally, I find I always have this at the back of my mind, how to balance everything and not to give a part more than the other.
Well, I think you bring in a very important point, Abdullah, which is work-life balance. Now, during my training, we never had anything like that. We obviously had work, which is probably not the right thing, I would say, at this environment. We went during my training, I went for my weekend on call on Friday morning, and I came back on Monday at 10 p.m., stayed in the hospital, couldn't see my kids for an entire 4 days. Now, I don't think this is the right thing to do, to be honest. I would say you have to have some sort of a work-life balance. Now, you probably know my interest in sports, and I've spent actually quite a bit of time in sports. Mine was Taekwondo, and I spent time practicing it, then became obviously the president of Saudi Taekwondo Federation during my time when I was in Saudi. You have to have something else in your life. And I think that something else is going to help you persevere in your career. And I would say if that something else should be sports, and only sports, I would say. Physical activity. That something else could be art. If you're an artist, you want to draw, but it cannot be social media. It cannot be. I think the social media is an incredible eater of time with very little benefit. So you have to be very careful with what else can you rehabilitate your mind. The physical activities is really important. It really adds a lot to your brain and to your physique, as well as to how you think. Because every time you do any sport, you achieve a target. And every time you achieve a target, that's a success, which means that if you, every day, I try and exercise every day. I can't do it every day, but I do anywhere between 4 and 6 times a week, depending on my time. But you got to dedicate time for sports. And yes, I think at this day and age, you really have to create some sort of a work-life balance. But I find, and I'm not being critical of what is happening now, people are talking about work-life balance with more life than work balance. As in, oh, I need to have my time off. No, I cannot do this. Oh, I'm tired from last night. No, I need to do this. And that's the issue. I think you got to be honest with yourself when you start talking about work-life balance. Yes, you want work-life balance, but look at your hours that are non-work and see what are these hours. Are they truly of added value to your wellness? I think your wellness is important in order to achieve, but this wellness cannot be sitting on the phone with the social media. That wellness may be walking out, maybe exercising, maybe socializing with people, but not with the phone. Maybe, so this is how I look at it. Maybe you could say you're an old timer and you know the social media is now what everybody does, but you got to create some work-life balance. But don't forget, you are in the foundation time of your life. Remember this. This is your foundation time. You're going to have a lot of your life later on to enjoy, but this is foundational for your future. This is where you get the best out of your time. So you can have more holidays and more times off when you get later on in your life. You're now mentally ready, physically ready, you're in the right spot, right track. This is where you want to get your most. So a little more work and some life balance would be great also.
Yeah, thank you very much, Dr. We have a question from Dr. Hani Mufti, but his mic wasn't working. Dr. Hani is a congenital...
I know him. I know him well. Hi, Hani. Pleased to see you here. Yes, absolutely.
Yeah, he's asking, how should a junior consultant surgeon deal with lack of mentorship in their new institutions, and how can you innovate if the environment is not supportive?
Okay, the first question, lack of mentorship. It's a problem. Keep thinking. As a resident, you lack mentorship. Really keep looking for a mentor. Mentor within and in your institution. That's the thing, is within your or neighboring institutions, because that's what you want. I was lucky maybe when I was in the general surgery program at King Khalid University in Riyadh. I was an R2, and when they were saying, "Oh, if you," my senior registrar, when he was asking, "Oh, if you want something, go and ask Hani." The senior registrar is diverting the residents to come and ask me rather than him answering. I realized that I don't have mentorship. If that person is the senior registrar is referring to me for a reference of knowledge, there's a problem. I'm the resident. He should know more than me. I realized that I needed to do something else and go somewhere else. But yeah, keep looking for mentorship. That's important. That's one within your environment, and even if it means outside. It may not come very quickly, but you should seek it. Innovation question for early career and mid-career surgeons is always going to be a problem. And I think if we were to innovate newer operations, the first question you're going to face around you in Saudi Arabia, let me say to be specific, is what if they haven't done it in Mayo Clinic, why should we do it? That was the first question you're going to face. And I have been faced with these questions, by the way, through my early career. And my answer to this, first of all, for you to innovate something new, you got to be good at what is being done at this point. So I can't innovate, let's say, something new in aortic valve replacement, and I can't do a good aortic valve replacement. Be good at it. Work hard, make sure that your results are good and you're doing well. And then when you start saying, well, I am doing actually good at this, and that's why I want to innovate. I want to actually change this to even better techniques. And that's why. And then you got to be that person that people trust. And that's what I'm saying is this is not going to come within a year or two. This is your build of your career, your entire career. If every one of you now, after this webinar, I will ask you this question. Go and write on a piece of paper, what are the 3 characters people will describe you? What are the 3 characters people will describe you? Just put them down on a piece of paper. Be honest with yourself. Are they going to describe you being a hard worker? Or are they going to describe you being honest? Are they going to describe you as being superb technician? Are they going to describe you as, and be honest with yourself. Are you that person or not? So, and every time I interview fellows or residents for our program, you know, I started cardiac surgery, congenital cardiac surgery fellowship. These are people who finished their adult fellowship. And I asked them these questions. If I were to ask the people around you how they describe you with 3 characters, what are they? And believe it or not, a lot of them don't even know how to describe themselves. So go around tonight, ask yourself, what are my 3 characters that people will call me for? And this is important because if people are gonna call you, and you know, do something even better. What are the 3 good characters that people will call you for? What are 3 bad characters that people will call you for? Be honest with yourself. Once you identify these 3 bad characters, work on them. Because the first thing is you identifying what are your 3 bad characters. If you know them, if you're late, just tell yourself, I know that I'm late and I should change that. I cannot be late for rounds, not even a minute. I swear I look at my phone every morning and it's 7:00 that I start rounds. And if somebody does not show up at 7:00 from my fellows, it's got a problem. So look at that. Look at your 3 best characters and 3 bad characters and improve on your 3 bad characters.
I think it's been nearly 2 hours since we started. Thank you very much, Dr. Hani. We are really grateful and thankful for your time, valuable time. And we're really looking forward to have you here our academic activities, Saudi World Cardiac Surgery. Thank you, Dr. Hani. Thank you, everyone. And
Abdullah, I want to thank, before you close, I want to thank you and Loy for inviting me. I'm going to be in the Saudi Heart in October, and I'd be happy to meet with you physically, and we can meet and have an hour together. And if you want more of this, I'll be delighted to share my life experience. I'd love to see all of you leading your programs, leading the world in heart surgery. We have led the world in many areas in heart surgery. We have a track record, and we should build into that. Thank you so much again.
thank you.